Hello, and welcome to the Feeling Good podcast, where you can learn powerful techniques to change the way you feel. I am your host, Dr. Rhonda Borowski, and joining me here in the Murrieta studio is Dr. David Burns. Dr. Burns is a pioneer in the development of cognitive behavioral therapy and the creator of the new team therapy. He is the author of Feeling Good, which has sold over 5 million copies in the United States and has been translated into over 30 languages. His latest book, Feeling Great, contains powerful new techniques that make rapid recovery possible for many people struggling with depression and anxiety. Dr. Burns is currently an emeritus adjunct professor of clinical psychiatry at Stanford University School of Medicine.
Hello, Rhonda.
Hello, David, and welcome to all of our listeners across the country and around the world. This is the Feeling Good podcast, episode 383, and our very special guest today is Robin Mathy. Robin described herself as a human who hopes. I love that. She's a doctor of social work student, as well as an LGBTQ plus mental health specialist. She does telehealth and online therapy with people throughout California, and she's also available for consulting if people have questions about this topic. So welcome, Robin.
Hey, thank you for having me. I'm honored.
Nice.
We're honored too. We're thrilled to have you. I'm really looking forward to the next hour and getting a lot of questions answered. And we haven't, have we ever done a podcast? Well, we have done some of this, like with Kyle Jones, but
nothing on this specific topic.
No. So we're really grateful to have you, Robin.
Yeah. And so I'm going to just read two brief endorsements about our podcast 376, which was part one of the personal work, David, that you and I did with Jessica called Living with Regrets. And two people wrote in. One said, "It's always beautiful to see turning points in the treatment. I loved with the positive reframing the section where David talked about OB and grieving. And I always admire people who do not procrastinate. Maybe that is why some ex-top sports people, men and women, are successful in life. They've learned to pay a price for performing and success, and they're willing to do all the work needed. They are capable of accepting help, coaching, and healing." And the second, that was from Bill, who sends us endorsements all the time. And
that was from who?
Bill.
Phil. Oh, yeah. But those were both. That was one from Phil. And he loved the part about OB and grieving and loss. And we all encounter loss pretty often, sadly, in our lives. And then also he was liking, I guess, with Jessica, being an athletic performer as a ballet dancer, had to really know how not to procrastinate. I guess that's what he's referring to. And really commit your life to something, something our current guest has in common as well.
Yeah, and someone just wrote very simply, "This episode was a nice Christmas present. Thanks, David, Rhonda, and Jessica, and everyone who made this episode possible. The content is worth the lower audio quality."
Yeah, well, thank you for that. And we hope that you also enjoyed what was published yesterday, although it won't be yesterday when this podcast comes out, but part two of the Jessica work, which was, ended on a triumphant note. And it sounds like she's doing great. I recently heard from her, and she's going to be coming up the United States, or maybe from Miami, to be a trainer in an upcoming team CBT intensive in Southern California. So she's really excited about that.
Nice. Well, Robin, you're talking about transgender clients and gender diverse clients and how to work with someone who comes into your office and maybe they present that as an identity issue, or maybe there's other things going on in their life, and they're perfectly content with who they are, but they're feeling depressed or anxious or coping with something else. And we wanted to talk to you about, what best approach should a team therapist take?
Yeah, I think that's a really great question. And I think whatever approach one takes with this population, it's really important. One is be affirming, which means being supportive and accepting. And then I would say the second thing is to not assume that because someone identifies as transgender, gender diverse, that that's the reason they're presenting for treatment. I think I've seen a lot of clinicians make the mistake, for example, of saying in their treatment plan that they're going to refer the client to a transgender support group when there's nothing in the presenting reason or chief complaint about their gender identity whatsoever.
Yeah, that's kind of kind of an insult to treat people that way, or with any kind of formulas. That's one thing I love about TEAM, is every person becomes an absolute individual with their own problem, and the approach differs with every single patient. But so let's go down to some basics, and starting with the kindergarten level for those of us who are not that up in an area where we should be. But can we start out with something like, what does LGBTQ stand for, and what do those letters mean? And then what are the various dimensions of transgender, and what's the relationship between sexual attraction and gender identity? But let's start out with something really simple. And then once we get these basics down, then we can get into some of the more sophisticated and important things you want to say. But let's, I think you have some beautiful videos that I recommend on YouTube, and you can link to some of those in the show notes if you like. But in one of them, you were, I can't remember what I was going to say, but I think it was the first one.
And how there were more, it's a false assumption that there's only two genders. That one?
Well, yeah, that's certainly a thing. Why don't we just start out with the definition of some of these concepts? You were saying that there's so little education about this, and I had to admit, I've taught at Harvard Medical School. I went to Stanford Medical School. I did residency at University of Pennsylvania Medical School, and I don't recall ever getting anything on gender identity or diversity. I remember once there was some kind of a survey to ask us if we thought we were knowledgeable about sex and sexuality. And since I'd had sexual intercourse on a number of occasions, I tacked off that I thought I was knowledgeable. And I didn't even realize what I was saying at the time. So let's start with some of these words and what they mean.
Sure. All right. Well, related to the first question, LGBTQ stands for lesbian, gay, bisexual, transgender, and queer questioning. And so basically, the transgender refers to gender identity. All of the others, the LGBT, lesbian, gay, bisexual refer to sexual orientation, which is romantic or sexual attraction to people. Gender identity refers to one's sense of self as a man or a woman, or as male or female. It can really be either. And transgender refers to people whose gender identity, whose sense of self as man or woman, male or female, is incongruent with the sex that they were assigned at birth. So, for example, somebody might have been assigned female at birth, and around ages 9 or 10, they become aware that they're actually a boy, or that they want to have male physical characteristics, and don't want to have female sexual reproductive characteristics. Then that person would be considered transgender. I think an important thing to note is that we use transgender as an umbrella term that refers to pretty much anything that is not cisgender. And cisgender means that someone's gender identity is aligned with their sex assigned at birth. And so one of the problems I see often is that providers will make a note of anyone who appears to be gender incongruent, or who has a gender identity or expression different than their sex assigned at birth. They may refer to them as transgender, but there are a lot of people, a lot more than you may realize. There are a lot of people like me who do not identify as transgender. I identify as a female or a woman assigned male at birth. But because I see myself as a female, I really feel offended when people refer to me as transgender any more than they would refer to any other woman as transgender.
Say that again. Again, this is why we have to get the basics really clear, because I thought you were going to say one thing and you suddenly were going in a slightly different direction, which sounds incredibly important.
Yeah. So
you said a lot like me.
Yeah. So there are an untold. I mean, we're not measure a subpopulation of people who are considered transgender, who do not identify as transgender. We don't identify that way. So, for example, I can acknowledge that I'm gender diverse and that I was assigned male at birth, but I identify as female and a woman. And I'd say it would be very alien for me to say I'm transgender. And so that can affect questionnaires, for example, on office intakes, where you might want to be culturally competent and include a space that says, what sex are you, or what gender are you, and have a list of male, female, transgender, non-binary, and I'll talk about non-binary in a minute. But that list does not tell you whether or not a person is transgender, because there are people like me who are going to answer female. And so what we do now for office intake forms and things like that is ask, what sex were you assigned at birth?
I don't get the distinctions. You got a slow student here, but I'll be speaking for a lot of our listeners who are probably as slow as I am. You say, I feel like I am a female. I'm gender diverse. I was assigned a male at birth, but I feel I am female, so I respond that I'm female. So I thought that's what a transgender man would be, or transgender female would be. I'm probably sound like an idiot, but
No, not at all. For me, it's like I've been working in this area for over nearly 4 decades, so it is hard. There's that gap between what I know and what I realize others don't know yet. And my goal is to provide information, and so I apologize. I'm not doing a better job of that. So the basic point is that many people who might be thought of as transgender do not themselves identify as transgender. And what that means is that someone else may look at the population and say, well, if you don't identify as with the sex that you were assigned at birth, then you're transgender. And what I'm trying to point out is that isn't necessarily true.
This is fascinating. And then why isn't it true?
The concept of being transgender refers to that incongruence between one's sex assigned at birth and one's gender identity. The problem is that there are a lot of people, and I'm using myself as an example. I don't feel that I ever transitioned from being male to being female. I feel that I transitioned from being me to being fully me. And so
you always felt like a woman, even as a little girl.
Oh yeah, I always, and not just felt. I think that's an important distinction too. Is I saw myself as a female. My first recollection of being incongruent was when I was taking a bath with my sister, and probably we've all heard of Freud's penis envy, and for me it was actually I saw that I had something that didn't belong. My sister didn't have it, and I really thought it shouldn't be there and didn't belong to me, and so that really increased my awareness that I had the wrong body, so to speak.
I see.
So,
gosh, Robin, I love.
Did your parents raise you as a little girl or as a little boy?
Initially, they raised me. They raised me as a little boy, and they didn't do a very good job of it. I was very effeminate, and they were not accepting. And at that time, it was the 50s, 60s, 70s. People didn't talk about it very much. So there was that.
I love your description of transitioning from me to fully me. That's just so heartwarming.
Thanks.
And yeah, I really get a sense of like freedom and fulfillment to be yourself.
Yeah, I think I had a therapist. I don't think she ever quite understood it. But she was talking about me wanting to be a woman. And I said, and I'll say it slowly because it might be confusing. It's not that I want to be a woman. It's that I don't want to not be a woman.
Mm-hmm.
Yeah, right. Yeah, that is a very important distinction. Does that relate at all to the talk that you gave on the genetic androgen and sensitivity, or is that a completely independent topic? Because that was fascinating also.
Yeah, it relates. I think that ties into now the common misconception that there are only two sexes. And so just to clarify what I've said so far, we have LGBTQ, which is lesbian, gay, bisexual, transgender questioning. And the LGB refers to sexual attraction or intimate attraction. And transgender refers to gender identity and people who have a gender identity or a sense of self as male or female that is incongruent with their sex assigned at birth. Now we're going to talk a little bit about sex, which, as everyone is pretty much taught to think, is about reproductive organs. And so most people will begin with chromosomes. We have 23 pairs, and we refer to it as 46 XX chromosomes or 46 XY chromosomes for males. And the problem is that suggesting that there are only two sexes implies that everyone is either 46XX or 46XY. And in reality, we can think of sex as a very wide U-shaped distribution, such that most people are either 46XX or 46XY, but there's a very broad spectrum of other chromosomal makeups in between those. And one of those happen to have 46XY. So chromosomally, they're male, but their Y chromosome, well, I won't say it that way. Their chromosome does not activate the androgen or testosterone receptor. Androgen and testosterone are predominantly male sex hormones. Both males and females have them. Males have about 10 times to 15 times as much as women. And in the case of people with complete androgen insensitivity syndrome, their sex chromosome does not activate the onset of testosterone. Their bodies don't take it in or use it, and so their bodies develop like any normal woman, with the exception that they usually do have testes, but by all indices, their external genitalia are just like any other woman. And usually the condition isn't detected until late adolescence or early adulthood. But that ties into the, I promised I won't go too far down the transgender athlete rabbit hole or anything like that, but it does tie into things like the bathroom bills or transgender athletes, because essentially saying someone who's born with 46XY chromosomes must use a men's restroom ignores the fact that there are many people who are not born or who are even born 46XY chromosomes who do not appear female or do not appear male. And it would be cruel and dangerous to require them to use the men's restroom simply because of their chromosomal makeup.
Yes, right. Some XY do not appear male, even though they have the prototypic XY male chromosomes. For example, if they have androgen insensitivity, they're going to develop as a male, as a female, and even with a great impact on the sexual appearance. They could have testicles, but they're not going to develop a large penis, and they're going to have the appearance of a woman. And then to insist that they use the men's bathroom and to prevent them from certain athletic competitions would be actually quite cruel. And you had a couple of photos there in one of your YouTube excellent short, I might say. That's one thing I like about your talks. They're kind of short and to the point, but two beauty contest winners who were in that category. They had XY chromosomes, but they had apparently androgen insensitivity and looked exactly like women, if I got it right.
Yeah, actually, they didn't even have androgen insensitivity syndrome. They were just like any other XY male.
Oh.
But they, they took hormones and started entering beauty contests with
I
other
see.
women and ended up winning. And, you know, as I show in those photos, they separately won their nation's beauty contests and were qualified for the Miss Universe contest. And so I think the point that I made in that video is I think a lot of people who are opposed to transgender people think of transgender people as very different than the spectrum of people that exist. I'm being confusing. Let me say that the stereotypical truck driver, kind of a big, muscular, brawny person, is, I think, an exemplar of what opponents to transgender people think of as when they think of transgender. And the reality is the vast majority of people who are transgender at a certain point in transitioning so that their physique or physiology, physical form is consistent with their gender identity, simply would not appear any different than any other woman. And so it would be very cruel, inhumane, and dangerous to compel someone who appears as female as any other woman to use a men's restroom because one's biases are that people who are transgender stereotypically look like big burly men wearing a dress. And I've actually read books by people who were not trained as human sexuality researchers who make assertions like you can always tell, or it's obvious. Even your nature senses will tell you, and that's just complete rubbish.
Yeah, I think I told you when we were talking about this, Robin, that I was I've mentioned before that I was a martial artist, and there was a woman in the martial arts studio that was one of my students, and I worked with her for about 8 years. I had no idea that she was transgender until finally she told me. And it was interesting too. It's kind of what she was talking about when I was a little. She would always say, "Oh, when I was a little girl, this happened," or "When I was a little girl, this happened," and I know that she didn't physically transition from herself to fully herself until much later in life, but her identity as a little girl was so clear and full and like present constantly. Yeah.
Yeah, and to throw in another confusing loop, we now know that a lot of people actually don't develop or crystallize their identity as transgender or being incongruent until adolescence. In fact, in the normal progression of transgender identity development within the context of gender identity development, we know that one's gender identity generally coalesces around by age 7. And we also know that transgender identity development becomes more aware at around ages 10 or 11, about the time that kiddos reach puberty, which I find utterly fascinating. We could ask all kinds of questions in terms of evolutionary biology, why that would be, but I won't go into that. That would take us down another rabbit hole.
Well, let me go to bring it onto a slightly different level. Everything that you're teaching us is so patient and clear and helpful. But on another level, as I become older and perhaps more exposed to the world, I become more and more aware, I guess, as everybody, of so much hatred in our culture. It's just on display to a great extent in the last 5, 10, 15 years, but it's always been there. Like when I was even watching one of the playoff games on football games last night, I think it was, and the one of the teams was, I think, from Alabama, was one of the 4 playoff teams, and they were playing Texas or somebody, or they were playing Michigan. And then I saw they showed the cheerleaders there from Alabama, and they were, white as snow, and they were, leading the cheers for Alabama. And then it just occurred to me, I bet almost every one of them has a hatred, in a way that maybe on some level they can't help because of their home, their upbringing, but they probably have an intense hatred for Black people. And it was just like kind of, oh, wow, I'd kind of forgotten about that for a moment. And I was just wondering, and this probably more stupid questions from me, but I'm just going to shoot them out there and hope I don't make too much of a fool of myself or irritate you, Robin. But I can imagine that you've encountered, your share of hatred and bias and cruel treatment along the route, and along the way you've become a fighter too, a pioneer, researcher. You've published and done remarkable things, but on the human, more tender side, I'm just asking you kind of a stupid question, but have you been exposed to harsh treatment and cruel insensitivity? I probably have said stupid things myself, not even aware of. But what has your personal journey been like?
Well, first, if I may say, David, I think a lot of times people say there's no such thing as a stupid question. And I might disagree with that and say there is a stupid question, and that's asking something you already know the answer to. That would be a stupid question. But none of your questions are stupid. And I just want to validate that I appreciate your interest and desire in knowing and understanding. I really admire that attribute in others. So I encourage you not to shame yourself for having that curiosity or being apprehensive that it might be judged. And so, in terms of my personal experiences, I resonate with more recent research that shows that there's kind of a sweet spot, if you will, in transitioning that's called gender congruence. Gender congruence occurs when one's sense of self's gender as masculine, feminine, man, woman, boy, girl, etc., matches their physical appearance. And that differs for a lot of people. For some people, it can be very nominal. For others, it needs to be a great deal. In my case, I was very suicidal after entering puberty. The appearance of male secondary sex characteristics really repulsed and disgusted me, and I had to deal with that. And it persisted. It just doesn't go away. And that when I did start transitioning, then I was in a hospital following a suicide attempt, and a very kind gay psychiatrist, Dr. Ronald Hilding, said, what if we help you start transitioning in the hospital? And I was like, what? You can do that? And so that's really where I started my overt transition. But in the early days, because I wrestled in college and was a candidate to the U.S. Olympic team, which any therapist will recognize as compensation, I had a very muscular appearance. And so presenting as a woman in public, I wasn't gender congruent. And it was pretty clear to me that I was not appearing feminine or a woman to other people. And so I experienced a lot of ridicule, rejection, harassment, that kind of thing. Wow. And unfortunately, that does happen. In my case, when I reached a point of, I should also say that one of my first experiences getting hormones was going to an endocrinologist, and the endocrinologist didn't say anything overtly disrespectful, but her nonverbal communication made it pretty clear to me that she didn't want anything to do with me. But rather than saying anything, she left me in the inner waiting room while she went about her business. And because I really wanted the hormones and I'm very patient, I waited. It must have been a couple of hours. And she actually came back through at closing time and said, "Oh, you're still here." And I was like, "Yeah, I'm still here." And so there have been those kinds of experiences.
I'm so
Even
sorry to hear that.
Even after I became gender congruent, I'd had surgery, and now called gender confirmation surgery. Back then it was called surgical sex reassignment. I had to deal with other people's phenomenological baggage, and I really grew tired of that. And phenomenological just means that I had to pay attention to what other people's perceptions were, just as I assumed that they did the same of me. Mm-hmm. And I didn't like the reflection that they gave, that I had been living as a man, and I decided to dispense with that by moving to an entirely different part of the country where nobody knew me.
And you went from where to where?
I was living in Phoenix, Arizona at the time.
Oh, I lived there for a while.
Did you? Hot as anything?
Yeah, I can understand that might not have been the most comfortable spot.
Yeah, so I moved to Minnesota, which is where I ended up getting my master's social work degree.
Where did you live in Phoenix, if I could ask?
I actually lived in Mesa and Tempe, and kind of in the southern area of Phoenix.
Yeah. My dad was a minister in Phoenix.
See?
A Lutheran minister. And when he retired, I was shocked that he went to University of Arizona to so-called help gay students, kind of become Christians and change their sexuality. And, I was so angry and ashamed about that. We never reconciled. And
and I'm just reading a book now about sexual orientation change efforts, which used to be called conversion therapy.
Yeah.
Nothing therapeutic about it. So now we refer to it as sexual orientation change efforts. And there's a corollary for gender identity change efforts. And of course, there's a huge problem with that because, you can't really change someone's sense of self as male or female, man or woman.
No.
and ironically, the really dramatic increase in laws and regulations that ban gender affirming care or supporting adolescents in working toward gender congruence in a way as a form of gender identity change efforts because they're not allowing the kiddos to develop as they see themselves.
Right.
And I think it's most people probably don't realize, but it really is the attacks on the transgender community have really escalated in the last 3 years.
Yeah.
The first ban on gender affirming care didn't come into place until 2021. Mm-hmm. And there are now 24 states that ban gender affirming care. The same number of states in the past 3 years, the same since 2021, now ban transgender athletes from competing in the sport that in the sport category, gender category they identify with. And so I guess that's just for me a major point. It's probably the major reason that I came out as being a woman assigned male at birth back in March. Mm-hmm. Was because I felt like we needed more seniors among us to really say that we need to do something about this.
In anticipation of today, I looked it up. And in 2023, there were 500 anti-LGBTQ bills introduced in state legislatures in the United States across the country, and many of them, if not most of them, targeted the transgender community. One of the other things that is really scary is that there's a lot of violence against transgender and gender nonconforming people. I think from what I looked up, and hopefully this is accurate, 33 people were killed in 2022 and 26 people were killed in 2023. And most of them, the majority of them, were people of color, like Black transgendered women. And so, it's a dangerous time to be true to who you are if you're, transgendered or.
Well, and a lot of it really does directly relate to how people in our society are socialized. And so in my videos, for example, David can probably verify this. I'm very careful to be evidence-based. I put the citations and the references in there. I admonish viewers to check out the resources from themselves. Don't just take my word for it. And those are things that we don't see from the leadership against transgender rights or transgender health. They simply want to boil it down to there are only two sexes. Why? The Bible says so. Really, I think anyone who's studied moral development can say, well, that kind of right and wrong thinking is pretty young, not very mature.
Yeah, that's why I drifted away from the church, because it just seemed to me it was standing for hatred rather than love. And it was very pronounced in Phoenix, but now it's getting pronounced all over the world, really. Yeah. And it's terrifying and maddening.
I just finished with a colleague a paper on transgender athletes. And I actually include a quote by a couple of Russian researchers. Well, I don't include the quote because you can't do, well, anyway. It's a passage in their paper published in Russian that says the reality, or it's a fact that some people are so desperate to win competitions that they will change their sex. Totally unsubstantiated, but that kind of statement, and David and I have talked about that. Once that kind of statement makes its way into peer-reviewed literature, other people cite it, and it becomes reified as fact rather than something that had no substance in the original publication. And if you read research carefully, you can see those kinds of comments all over the literature. Some of the basic research in sex differences, and now I'm just talking about XXY chromosomes and XX chromosomes, people, and the variations in between. You can really see that there's a lot of people that make statements like because males have more testosterone in utero, then they're naturally more aggressive than females, and that really reflects such ignorance of cross-cultural norms. If that were the case, then we would see males everywhere be more aggressive than females everywhere, and that's not at all the case.
Tell us more about that, because I thought that was fairly well established. You see, the prisons are 90% male, and men seem more aggressive, and everyone's saying if we get some more women for president and leaderships, we'd have a more peaceful world. But you're saying that might not be valid?
That is, definitely not valid. What we know is that
Wow.
the aggression is expressed differently in men and women. Adolescent girls, for example, tend to be just as aggressive as adolescent boys, but they tend to do it in less direct, not physical ways, but in social ways. And one could argue that, that can be every bit as harmful. For example, we know that internet bullying or that kind of social hostility can set an emotionally vulnerable person up to be suicidal or depressed. And so that's a common kind of misconception. It also ignores the fact that there are so many other factors involved in aggression besides just a biological predisposition or disposition that we really can't attribute it to just testosterone. It's really so many other things. And yet a lot of people who talk about sex differences continue to kind of promulgate this narrative that because males have higher levels of testosterone, they're more aggressive. And I would challenge you to go to the mat with any female who studied jujitsu and tell them that they are not as aggressive as a male. It's not going to end well for you.
I agree with that.
To ask you a question, I have another question I've been meaning to ask you. You probably answered it earlier, but would it be fair to say that testosterone does not enhance aggression? For example, if we were to give people a lot of aggression, a lot of testosterone, men or women, is it well established that they would not become more aggressive or violent?
That's a different question. And I would say, number one, definitely not violent. Violent requires something other than aggression, a certain malevolence or antisocial lack of empathy, all those characteristics. And so, no, definitely no to violence. As far as aggression, we have to define what aggression is. And if we define aggression as motivation to cause harm, then the answer is no. What we see is males are more physically aggressive and females are more socially aggressive. Both males and females have testosterone. And so we see a difference in the outlet. Could we say that males, because they have a higher level of testosterone, are more physical? Yes, definitely. And we see that in the prevalence of things like rough and tumble play among boys versus girls. But even then, we can't say that it's just testosterone. The reality is that we used to ask, I think 20 or 30 years ago, we used to ask or have arguments about, is it nature or is it nurture? And now we recognize that it's both nature and nurture, and we really can't separate the two out. And so Sir Michael Rudder, extremely well published, very prominent researcher, did a keynote speech at a developmental psychology conference that I attended, where he emphasized that point and said a lot of the research that we have about gender differences or sex differences really is wrong, because it's asked the wrong questions about, is it nature or is it nurture? And so I would say that the real test of any hypothesis is not to prove something, but to set it up to say, how can I best disprove this idea?
Exactly. Yeah, right. That's what SEM is all about, by the way.
Yeah. And so really the best way to test the idea that testosterone is the predictor of aggression is to say, are there any instances where females are not as aggressive or more aggressive than males? And that leads us into a very conventional problem among mental health researchers, social science researchers in general. You can point to an average and say, on average, males tend to be more aggressive than females. But given any particular person who is male relative to any other particular person who's female, you cannot accurately predict which one of them will be more aggressive.
Right. Okay. That's a good answer. The other question is, you've mentioned, you've used the word queer, but I'm not sure that we've defined it, or you might have mentioned it, but can you describe that one from the LGBTQ list?
Yeah, thanks for asking. Queer is an umbrella term that refers to pretty much anyone who's not heterosexual. And because now we recognize so many different identities beyond just lesbian, gay, bisexual, and we don't have time to go into all of them, of course, but we just say queer. And the interesting thing about the word queer is that it used to be quite a pejorative term, and the lesbian, gay, bisexual community reclaimed it and took back its power, so that the word queer is now a positive connotation rather than a negative one.
That's good.
Does that answer your question, David?
Yeah, very well. As a matter of fact, yeah, and the I'll add that. Well, I'll just ask a question based on what you just said. The positive connotation. And this is probably another stupid idea, but I've often thought that people who are bisexual in a way are kind of superior to people who are unisexual, because they have a broader capacity to experience and enjoy human sexuality.
Mm.
I don't know if that makes any sense or sounds stupid.
Yeah, and I can see why we would think of it that way. The reality is that people who identify as bisexual actually have, on average, there's that average again, worse mental health than people who identify as gay or lesbian.
Oh, interesting.
And I think part of that is because people
They're
who are
more marginalized.
people who are bisexual tend to be marginalized within the queer community. There are a lot of people who are like, you need to decide you're really either gay or straight, rather than acknowledging, what we've known since Kinsey, that a lot of people are not strictly, heterosexual or gay. But yeah, there's, everything from depression, anxiety, self-harm, suicidal ideation, suicide attempts are higher among bisexuals than for gays or lesbians or heterosexuals.
Oh, interesting. I had no idea.
Well, Robin, we didn't give you much empathy when you told us about your experience feeling
Yes, we didn't.
suicidal. And I listening to you, I felt so sad that you went through that.
Yeah, me too.
And really so grateful that you ran into a psychiatrist who is gay who could be supportive of you immediately. And that's also seems to me probably pretty rare. And I'm really glad that you ran into him.
Yeah, it really made a difference. I think it speaks to, I think David is really good about that, but really meeting the client where they are, and being truly empathic rather than just kind of mouthing the words.
And then, so that brings us the full circle back to the first question. If someone comes to you and their identity is LGBTQ or, they're incongruent with their sex assigned at birth, how would a team therapist best work with that person? And you said originally be affirming and supportive and accepting and not pigeonhole them that they want to talk about their sexual gender. What other suggestions would you have?
I think with all of those caveats in mind, I don't think that one would do anything different. I think it's really the same. It's still the five secrets, and the same skill sets.
Yeah.
I would wonder, and it's not just about Team CBT, but I do wonder to what extent matching clinicians' sexual orientation or gender identities affects clients' perceptions of empathy. And so one variable I would think that would be important is, does the client know? And with a therapist like me, they likely would know. But 7 or 8 months ago, before March, they wouldn't. There was only one time that I disclosed to a client that I was assigned male at birth, and that was a very exceptional situation. And I published about it in terms of ethics of self-disclosure.
Interesting. I have another question for you. To come back to what we were asking a minute ago, you are an expert, and you're a wrestler. You're a fighter. You're feisty.
I was a long time ago.
Well, you still are. You're still doing all kinds of wrestling matches on all kinds of levels, as we all are. But the question I wanted to ask you is, you have a tender side, a sad side, and a side that's been, I'm sure, lonely at times, maybe even during this interview, and hurting, and I'm wondering if it is hard for you to show that side because you've been hurt so much and because there's so much to mistrust in the world, increasingly so. Just kind of a question, because even on the interview today, you've taken on the role of an expert, and an expert you are for sure, and a fighter you are, and we need experts and fighters like you. But I wonder too if it's hard for you, and if you have to be very careful when allowing yourself to be tearful or vulnerable or open with how you're feeling inside.
Yeah, I think that is such a great question. And I think I can answer it along two spectrums. One is I've literally been on the couch in therapy for decades.
Oh, I see. Wow.
And, I really believe in, as a therapist, staying in therapy to deal with my own stuff, such as countertransference. And then, getting good clinical supervision. And I'm really, I guess I would say I really demand good clinical supervision. I think people who know me know that I am really pretty non-defensive. And so I really believe that we grow best by honoring the feedback that others give us. And in terms of a hard shell, I would say, yeah. I think for me, the way that shows up is I've been through so much and overcome so much that nothing intimidates me. I'm just like, I meet, high-ranking, highly respected authorities like you, David, and it's like, yeah, you're a leader and you're well respected, and I respect and admire that, but that doesn't in any way mean you're any better than I am. You still have to, take care of your bodily habits and put on your clothes like everyone else. And so
actually, when I achieved enlightenment, I was able to turn off all my bodily functions.
Oh, really?
Yeah, really? So I don't have to go to the bathroom anymore or anything
really?
Like that. Oh,
yeah, so I think, that, and when I do have, I think like anyone who's worked through their issues, I can't pretend that I don't have interpersonal with some issues with some people at some times, but I'm really invested in repairing relationships and maintaining them. And that's a pretty pronounced change. When I was first transitioning, I was so raw that it was like,
wow.
I was very reactive at that time. And so I do see a correlation, at least in my life and in other people's lives, for people who have transitioned, where at a certain point, you could say it's not just gender congruence, but life congruence, and authenticity, where it's like, I think, as I said at the beginning, how to identify I'm a human who hopes. I make mistakes and I learn from them. I'm way beyond shaming myself because I made a mistake. One of the things I love about Team CBT is the motto, about failing, because I think accepting the fact that we have to be willing to fail fast when we're learning new things is really the only way that we can develop some consciousness of our incompetence and build on that to reach some competence, awareness of competence, or mindful competence. And, then eventually we might reach the point where David is at, where we tie our shoes without having to think about it.
Yeah, I can. I learned that too. I just look at them and they tie themselves.
Isn't that amazing?
I love what you're saying. I hope you don't mind my ridiculous humor that injects itself into almost everything that I do. But I just
Not
love
at
what
all.
you're
I love
saying.
it.
And I'm wondering, you call yourself, maybe as a last question, as a human who hopes. And could you tell us a little bit about your hope, Robin?
Um, yeah, um, I think even, in my own personal recovery, um, it was kind of strange. It was like even in my darkest hours when I felt hopeless, I still had a glimmer of a hope that I could hope.
Mhm.
And I don't know that will make them. But for me now, it's like even with the most difficult clients that I have, um, I have hope for them finding, if not with me and not with the therapeutic techniques that I use, the hope that they will find a path to their recovery so that they can have a life worth living. Um, and realizing along the way that path is not going to lead to a miraculous world where there are no issues or problems or conflictions, but that they're able to cope with them without losing their authenticity and personal integrity. And I guess my bias in terms of mental health is that is the absolute worst part of mental disorders, is that it compromises people's sense of self-integrity as a whole being, and their authenticity, their ability to be themselves. I really like Carl Jung's passage that the privilege of a lifetime is becoming who one really is.
Mm-hmm.
That's a beautiful one.
Mm-hmm.
When I was a young psychiatrist just getting started, I once asked Aaron Beck, well, what do you do if you have a patient who seems genuinely hopeless and worthless? Because I used to and still experience, like when I start working with someone who feels severely depressed, they make such a good case that they're worthless and hopeless that I always get hypnotized by them at first and start thinking, I think this one really is worthless and hopeless. And then a few weeks later, you realize how off base you were when they're beginning to recover. But I asked Beck, what if you come across someone who really is hopeless? What then? And he said, well, he says, David, that's a decision that you have to make. But he said, but for himself, he'd never given in to the idea that any patient is hopeless. But it says you have to make your own policy there, how you're gonna look at it. So after that, I said I'm going to do the same thing. I'm never going to believe that any patient is hopeless. I'm never going to give up on a patient. Now that didn't mean that I believed that someone with schizophrenia would become non-schizophrenic. I mean that's ridiculous, and that's not even healthy. We don't have a cure for schizophrenia, but in terms of feeling worthless and self-esteem and hopeless. And so I never gave up on anyone, and that always paid up. There are a lot of patients that couldn't stand me and fired me and went away and hopefully found somebody they liked better and worked with better. But if they were willing to stick with me, I always stuck with that. And of course now in the later years when I can see such profound changes in almost everybody within a single therapy session. It's just the greatest thing in the world is to see that joy come into the face of somebody who's been feeling horrible and downtrodden. It's really what I live for, and it nourishes me as much as it nourishes the person who's undergoing that kind of change. One last question. You said you kind of came out again in just May of 2023. 3. And can you just give us another word or two about that? Because I was, kind of surprised and really intrigued by that.
Yeah, sure. I guess I reached a point of gender congruence, and people would, literally act surprised. I guess they were surprised if I disclosed that I had been assigned male at birth, and there were very few instances where that happened. But because of the really malevolent, excoriating attacks on the transgender community, especially our community's youth, I really felt compelled to call out other social workers to advocate for our population, which they hadn't been doing, still to most part are not. And really, I felt I could do that more effectively if I said, hey, look, I know what that population, I know something about what that population experiences. But I can say that there's a really hard trade-off, and I'll give you one example. For almost all women, or like all women, we go in for a mammogram for breast cancer screening, every couple of years. And invariably, they ask 2 questions, how much caffeine do you drink? And when was your last menstrual period? And for me, identifying as female, I was always in a really, I was really in a kind of a trap. If I answered honestly, and honesty is very important to me, then I had to sacrifice my 100% authentic identity as a female. And if I chose to be dishonest, then I could maintain my identity. And so that choice is one that I don't think heterosexuals or cisgender people are ever aware of or need to make. And yet, for those of us who identify strictly as the sex that we are now, and not the sex we were assigned at birth, that kind of thing comes up all the time, in physical interaction. So I went through probably a 10-year battle with the Veterans Administration, because I would read my notes, and I do, because there are mistakes and I want to correct them. But virtually all of the providers would write this XX-year-old, quotes unquote, transgender woman. And I made the point that is really no different than saying male nurse or female or male doctor or female nurse. That adjectivization really says that someone is other. And in certain medical interactions, except for when I'm having, a pelvic exam, for example, if I'm going in for a flu shot or someone to look at a sore knee, anything about my sexual identity is irrelevant. It doesn't need to be part of that medical transaction. And so my advice to therapists who are writing progress notes or other documentation is to be very careful not to refer to a client as transgender or any other term that they haven't told you that they want you to use, because ultimately your medical records can be used by others. And we often share our notes, and they can shape other people's opinions, and your client may not want those people to know. that they have transitioned or are transitioning.
You know what? It's just so comforting that to normalize the relationship between patient and therapist. And, you're emphasizing that when someone comes to a therapist, a team therapist, we would just work with them as we would work with anyone, that there's nothing different that we would have to do.
No.
And just give them acceptance.
But if we were working with you as our patient, then we would want to put in our notes that you're a woman, not that you're a transgender, whatever.
Yeah, exactly.
Yeah. Unless you were to identify, I'm a transgender, this or that, and then you could ask, can I use that term in my medical notes or my psychiatric notes or whatever?
Yeah, exactly. Because like I said, I mean, for me, it's like if I have a transgender client, someone who identifies as transgender, and they're coming to me for treatment of PTSD, I want to know how much, and I have instruments to assess that, but how much of their trauma history is related to their gender identity, but
Right.
not unless they say, my gender identity is a significant part of the trauma, and I identify as transgender and want to work on that. I would not include their identity in my records unless they specifically said it was. And so, for example, I think clinicians sometimes make the habit of saying, I would call it an error of saying someone who's transgender can be diagnosed with gender dysphoria and put that down in their notes. And the reality is that the vast majority of people who identify as transgender do not have the distress or impairments that are necessary to meet the criteria for gender dysphoria. And so if a client comes to me and says, I'm experiencing a lot of distress or dysfunction, impairment related to my gender, then I would do the assessment to see if they meet the other criteria for gender dysphoria. And, it might be an appropriate diagnosis.
Well, I'm pretty skeptical about most psychiatric diagnoses. 99% of what's in DSM to me aren't real disorders. Problems exist. And, humans exist. But once you transform shyness into social anxiety disorder, for example, you're making a maneuver which is not, to my way of thinking, for what it's worth, that it doesn't make sense. It's not a valid disorder. It's just people up on the extreme range of a continuum, and a lot of what you've been saying too, not so much today, but in your wonderful talks on YouTube, is that gender is much more of a bell-shaped curve than a dichotomy, the exact same thing. But that when you try to transform these things into disorders, or this is such a different kettle of fish, so to speak. That's where a lot of the discrimination and suffering comes in. If I don't know if I got that right.
No, and I absolutely agree. I think, as a researcher, we tend to focus on things like validity and reliability. And I have problems with certain diagnoses like borderline personality disorder. It's like somebody has to meet 5 of 9 criteria.
It's
but if you were
5.4.
5 of 9.
No, 5.4 of 9.
Oh, okay.
This is my stupid humor coming in again.
Okay.
Kind of agreeing with you through sarcasm.
Sorry. But that really means that you could have a whole host of people, pair them up and find that they have only one characteristic in common. And I, for the life of me, and I'm not trained as a medical professional, but I do have a master's in evidence-based healthcare from the University of Oxford, so I know a little bit about health. I cannot think of one medical diagnosis where a physician would say two different patients who have one characteristic in common of 9 have the same diagnosis.
Yeah. A lot of the diagnoses are very, very suspect. Schizophrenia is a real brain disorder. Bipolar 1 is a real brain disorder. Alzheimer's disease is a real brain disorder. But when you go too far beyond those, you're getting into very questionable territory. Well, Robin, it's been just a joy having you on the show today. We really appreciate your expertise and your, amazing technical knowledge, but also your humanness and your heart. We really respect you. We love you. And we're very grateful that you came and shared your enormous wisdom and knowledge with us and with our podcast audience.
Yeah, thank you so much for having me, David and Rhonda. It's really been an honor, and I really admire you, David. It's nice to be getting to know you.
Yeah, absolutely. The feeling is mutual, and hopefully we'll cook up some awesome projects together.
Yeah.
And me too. The feeling is mutual for me too. I'm glad to get to know you. I think if
Thank
we
you,
lived
Rhonda.
closer to each other, we'd be going to the movies.
Yeah, I bet. That'd be nice.
Okay, thank you.
Okay, thank you. Bye.
Bye.
Bye-bye.
This has been another episode of the Feeling Good podcast. For more information, visit Dr. Burns' website at feelinggood.com, where you will find the show notes under the podcast page. You will also find archives of previous episodes and many resources for therapists and non-therapists. We welcome your comments and questions. If you want to support the show, please share the podcast with people who might benefit from it. You could also go to iTunes and leave a 5-star rating. I am your host, Rhonda Borowski, the director of the Feeling Great Therapy Center. We hope you enjoyed this episode. I invite you to join us next time for another episode of the Feeling Good podcast.